Okay, so we're group 2 and we're doing non-viable cells, human and animal tissue. So for just a brief introduction, the use of skin substitutes in non-viable tissues in physical therapy wound care has dramatically increased in the past decade. It's attributed to advancements in technology, a decrease in research and production costs, and a shift in the standard of care with regards to wounds. Tissue materials used typically originate from animal or human donors, and synthetic materials are beginning to gain traction. There are a wide variety of products available that are largely interchangeable with regards to treatment approach. So for example, Epifix and Allopatch are both indicated for acute as well as chronic wounds, and also diabetic foot ulcers. So just some definitions. An autograft is a patient's own tissue donated from one part of the body to incorporate into another part of the body. And with the benefit of an autograft, it's decreased likelihood of rejection. And then an allograft is tissue taken or donated from another person to incorporate into the patient's wound. Acellular is tissue that is decellularized, leaving only the structure as a template for growth. And this has an increased likelihood of rejection and a longer recovery time frame. A xenograft is tissue taken from a donor of a different species than the recipient. Amnion is the inner membrane that surrounds the embryo in a human placenta. And a chorion is the outer membrane that surrounds the embryo, the amnion, and other membranes in the human placenta. So for the animal-based tissues, non-viable cells, we have porcine, which is pig, and its source is used because of their type 1 collagen content. Bovine is cow, and its source is used because of the type 3 collagen content, and it forms reticular fibers, creating a fine mesh tissue network. Some examples of this would be cytao, which is porcine or pig urinary bladder matrix. Integra is cross-linked bovine collagen, glycosaminoglycans, and synthetic silicone. Oasis is pig small intestinal submucosa. And then for the human-based tissue products, the acellular dermal replacement from donated human tissue, just some examples would be Allopatch Pliable and Alloskin AC. Adipose tissue replacement, the Leneva allograft adipose matrix, human adipose extracellular matrix. And then under the acellular dermal replacement from human placental membrane, we have the Epifix, which is dehydrated amnion and chorion allografts. Amnioband is dehydrated amnion and chorion allografts. Celesta would be made of the minimally manipulated placental allograft, and then New Shield is dehydrated placental and allograft that retains all placental layers.
Okay, so the purpose of the skin substitutes, this was a quote derived from one of the articles that we pulled talking about these different products, saying that the ultimate agent would be able to resist infection, lack antigenicity, be cost-effective, widely available, durable, stable, prevent water loss, and provide coverage for every wound's unique characteristics, including the wound location, depth, underlying etiology, and susceptibility to infection. They promote and favor a healing state by providing cellular matrix elements, by providing a biodegradable scaffold to promote synthesis of new functional dermal tissue rather than scar tissue, growth factors, promote growth in the extracellular matrix and reduce effects of MMPs in the chronic wounds, and then paracrine signaling functions to induce changes in nearby cells. Appropriate uses. So the wound environment must first be appropriate to begin tissue repair. This involves debriding any necrotic tissue and slough, adequate control of bioburden, management of drainage and exudates, adequate offloading and pressure management, diabetic foot ulcers, arterial ulcers, surgical wounds, venous insufficiency ulcers, and then other chronic or non-healing wounds. So human-based tissue indications for EpiFix, this would be recommended to use on wounds free of necrotic tissue or infection, people aged older than 18 years old, an ulcer duration of more than 4 weeks, so chronic wound, ulcer that does not probe to the tendons, so no tendons exposed. Alliscan AC would be used for partial and full thickness wounds, burns, and traumatic injuries. The Allopatch pliable, commonly used for diabetic foot ulcers, venous ulcers, and pressure ulcers. The Leniva allograft is used for replacement of damaged or inadequate integumental adipose tissue and reinforcement or supplemental support in underlying adipose tissue as a result of damage of naturally occurring defects. Celesta would be used for acute and chronic wounds, deep wounds, and cavity wounds. And then New Shield would be used for traumatic wounds, dehiscent wounds, and wounds with exposed bone or tendon. And then for animal-based tissue indications, for the two here that we have are Integra and Cytol. Integra was designed to be used in conjunction with negative pressure wound therapy. So anytime a wound needs to undergo NPWT, we use Integra. Management of wounds, including partial and full thickness wounds, pressure ulcers, venous ulcers, diabetic ulcers, chronic vascular ulcers, anything that's traumatic, such as abrasions, lacerations, second-degree burns, and skin tears, and then any draining wounds. The Cytol matrix would be used for management of wounds, including partial and full thickness wounds. Same deal, pressure, venous, diabetic, and chronic vascular ulcers. Difference here from Integra, tunneled and undermined wounds, and then surgical wounds, just like Integra, and then traumatic wounds such as abrasions, lacerations, and second-degree burns as well. And then some general risks and disadvantages. Risks for these types of dressings include possible disease transmission from any DNA that may remain in acellular tissue, outright tissue rejection from the recipient, infection, and osteomyelitis. And then the disadvantage is that these products have a shorter shelf life. Some can be quite costly, and then ethical dilemmas regarding use of placental tissue, and then some require refrigeration as well for storage.
So on to the animal-based tissue benefits with Integra. It maintains essential wound healing growth factors. It's fully resorbable, and then it's available in multiple sizes, so that's good for small wounds and large wounds. The Cytol matrix, it maintains and supports a healing environment through constructive remodeling. It contains basement membrane and numerous collagens, maintains an intact epithelial basement membrane. It's appropriate for both acute and chronic wounds, and then it also complements the standard of care. Some of the disadvantages and the risks specific to these two, you can see Cytol matrix has no really specific disadvantages. Integra has a couple where hematoma or seroma formation increase risk for infection, and then it also may require a second procedure under anesthesia. So then we are on to the human-based tissue benefits. And on this, the EpiFix is the first. So it's terminally sterilized for enhanced patient safety. Again, this one also has multiple configurations and sizes. And then it has a 5-year shelf life stored at ambient conditions. Alloskin AC is ready to use right off the shelf. It's pliable and stretchable for contouring to any wound and the maintenance of the wound bed contact. It's robust enough to have, to be able to have a suture or staple go through it. And then it encourages fluid drainage from the wound. The Allopatch pliable is aseptic processing, preserves tissues, the tissue's natural structure. It's ready right out of the package, just like the ones above. And it does not require rehydration. It's available in multiple sizes, and this shelf life is actually a 3-year instead of 5-year. And then it's flexible, thin sheet, conforms to the anatomy, and it always maintains surface contact. With the Leniva allograft, it's also ready to use right out of the package, ready for everything. And then it's decreased long-term health costs if it works out well. And then the preservation of natural derived endogenous components, it's vital, and it keeps those there. And then it also provides extracellular matrix that functions as a scaffold for patients' own cells to create new fat. These are some more. The amino band membrane. It's aseptic processing, preserves tissues, natural structures. It's ready right out of the package. It can be used in hydrated or dehydrated state. It's available in multiple sizes as well. The shelf life for this is also 3 years, and it is also flexible and conforms to the surface to keep contact. Celesta is a biological barrier with relevant inherent characteristics often used for therapeutic solutions. It has natural human tissue scaffold shields and cushions, as well as acts as a matrix for selective cellular migration, just as it does in utero. It's available in a broad range of surgical applications, including general surgery, wound care, plastic surgery, and urologic and orthopedic procedures. New Shield is the last human-based tissue, and it is the benefit of it has numerous growth factors and cytokines, and then just good properties like anti-inflammatory. It's also native amnion and chorion layers with the spongy layer intact. Some of the risks and disadvantages for human-based, there's ethical dilemmas regarding use of amniotic or placental tissue. The products can be expensive. They all require some sort of refrigeration, tissue rejection by recipient, and then increased risk for infection.
So some of the general contraindications for using these skin substitutes, if you have a sensitivity or allergy to like cellular tissue or any of the product components, you wouldn't want to use these. Some of them contain silicone and maybe a little bit of latex, and some of these patients may be allergic to them. If they've got an active, non-treated infection at the wound site or a systemic infection, you probably wouldn't want to use these. You need to get that infection treated first in order to ensure a proper environment for cellular growth. Active uncontrolled bleeding. Some of these wounds are fully resorbable and they're pretty good about being able to be used with drainage. But if you've got active uncontrolled bleeding, we need to get that under control before applying these. A malignancy at the wound site. You wouldn't want to introduce more tissue to a malignancy specifically at that wound site and give it a chance to grow a little bit more. And if a patient has an objection to using animal-based products or human placental tissue-based products, they're obviously not going to want to use this. Some of the research that we've found and conducted, a lot of the conclusions were general research conclusions that said, you know, we need more research. You can never have too much research. Most of the articles concluded that more research is required to continue the comparison between the existing standards of care and adding skin substitutes and using them in conjunction with the regular standard of care. They also concluded, you know, close collaboration is needed between these tissue engineers and practicing clinicians. If the tissue engineers aren't getting feedback from the clinicians about what's good and what's bad about their products, then we're not going to have any continued success or advancement in the development of these tissues. Standard of care, it is moving towards more tissue engineered techniques as a delivery of stem cells, because like 3D printing and bioscaffolding, it's becoming much cheaper and less difficult. It's becoming a lot more commonplace. There are clinical differences in wound types, though, that make it difficult to replace one standard of care with another. So we're going to see more of a gradual migration towards some of these techniques versus just kicking one out the door overnight. So an example clinical scenario that we thought of, this is actually one that I encountered on my first rotation. A patient, he was a 74-year-old male with a chronic non-healing wound on the plantar aspect of the head of his right first metatarsal. He's a farmer, so he's on his feet all day. He has a history of type 2 diabetes, heart failure, DPT. He was in stage 1 kidney failure and had a little bit of diabetic retinopathy as well. We did a Semmes-Weinstein test, and 5.46 was the smallest detectable size, indicating a loss of protective sensation in his foot. So he had a little bit of sensation problems in his foot, and actually when we were debriding him, he couldn't feel any of the debridement that was happening. The wound itself was an oval-shaped 3 by 5 centimeter wound. It had a macerated peri-wound area and a calloused hyperkeratotic rim. The wound bed was about 2/3 covered in slough, and the rest of it was eschar that wasn't too dry. It wasn't tender or painful to him upon palpation or probing. As far as musculoskeletal goes, he had decreased great toe extension range of motion and decreased dorsiflexion range of motion. He had hammer toes present at the second and third digits bilaterally. Overall ankle weakness, bit of a forward trunk lean during gait, not necessarily antalgic, but just a general lower extremity weakness, gait pattern. And he was wearing severely worn and deformed work boots that appeared wet. So his feet were not in the proper condition for wound healing, and his boots didn't fit him very well either. So we addressed that with him and instructed him to get better fitting shoes or boots or stuff that would help him kind of offload some of his pressure points. The interventions we used, we performed selective sharp debridement using a curette, forceps, debridement scissors, and a scalpel for some of that tougher callus tissue. The hyperkeratotic calloused rim, it was removed, revealing healthy non-callous tissue around the wound border. The wound bed was debrided using a curette, revealing 100% healthy granulation tissue. What we did was we put Integra over the wound, and we secured and covered it with Alleven Life for a little bit of pressure relief. And the Alleven Life has a shearing component where it's multi-layered, and it responds to shear a lot better. And then you wouldn't have to secure it with wound tape. We gave him a peg assist shoe and took out the pegs to offload that first metatarsal head. And we instructed him to wear it during the day and monitor it for signs of infection when he was changing his dressings. We gave him additional dressings, Integra and Alleven Life. We instructed him how to perform his daily dressing changes at home between his therapy visits and to monitor that for signs of infection. So our flow chart here, we had 3 different kinds of wounds: superficial, partial thickness, and full thickness. And then for each kind, we had either acute or chronic. And as mentioned at the start of the presentation by Jenny, a lot of these products are they're greatly interchangeable. You can use a lot of them for a lot of different things. Almost every single one of these products is indicated for acute or chronic wounds. The only difference is some of them aren't indicated for diabetic foot wounds or arterial or venous insufficiency wounds. And we kind of hit on that in our uses and purposes. The board exam questions that we came up with: number 1, your patient that you've been seeing for a chronic wound comes to you with their own research on a type of wound dressing that they believe will help them. The name of the dressing in question is Epifix. This is an example of what type of dressing or tissue: human-based non-viable, animal-based non-viable, human-based viable, or animal-based viable. The correct answer for that is human-based non-viable. Number 2, what is an example of a contraindication for using cellular and/or tissue-based products for wound care? Pain intolerance, anemia, infection, or burns. And infection would be the correct answer for that. You wouldn't want to place some of these tissue-based products on an infected wound. Benefits of using cellular and/or tissue-based products in physical therapy wound care include all of the following except: increased number of growth factors at the wound site, decreased presence of inflammatory interleukins, better reimbursement from Medicare, improved balance between collagen production and degradation. C is the correct answer for that. It doesn't matter what the reimbursement for Medicare is. That's not necessarily a benefit. We would use these if they would benefit the patient or not. And here are our references. A lot of our references came from woundsource.org along with our research.